Chapter 7, Prenatal Care. So the goal of early prenatal care is to optimize the health of the woman and the fetus, increase the odds that the fetus will be born healthy to a healthy mother, and then allow for initiation of strategies to promote health and early intervention in the event of complications. And what that's saying is, because of all these diagnostic tests that we're able to do, ultrasounds and labs, different things that we'll talk about further into this PowerPoint, we're able to see if the baby is going to do well or not. We're able to see complications that the baby might have. And if we see something like a congenital heart defect, we can send that baby out to a larger hospital, say Dallas, where they can go from an immediate C-section into surgery and be able to fix that problem. These are some of the goals of Healthy People 2010. Okay, so the first prenatal visit is going to be the longest visit. And in that visit, we're going to do several things, and it'll take a little bit of time. But usually the mother is very excited about it, and so it's not a problem. But first, they're going to obtain a baseline data. We want to know everything about the mother, everything about the father. So we're going to get a couple of, just confirm a couple of things. First, we're going to confirm that she is actually pregnant. We'll rule out any other diagnosis and make sure that it is a positive pregnancy. There are some things that can sometimes give you a false reading, a false pregnancy test, and so we're going to make sure that she is pregnant and has a fetus. We're going to determine the due date, and we talked about different ways of doing that. Now, Nigel's rule is one way. It's where you take the last day of her period, you add 7 days, and then you subtract 3 months, and you'll get her estimated due date. We're going to determine the due date by that. You can also do it by ultrasound. And then we're going to provide education on maintaining a healthy pregnancy. We're going to tell her the things she needs to do, the things that can promote good health, nutrition, and the things that she needs to avoid: alcohol, smoking, secondhand smoke, things like that. We're going to start doing a history tape. We're going to take all of her history, and we're going to make a very thorough history of not only her background, but also the father's background and the father's objectives. We're going to take a written questionnaire. We're going to do a face-to-face interview. We're going to have several parts to this history. First, her chief complaint. Well, obviously, it's probably that she's pregnant. She got a positive on her at-home pregnancy test, or maybe whatever it is, she knows that she is pregnant. Okay, so she's going to come in with that. Then we're going to figure out her reproductive history. Has she ever had a miscarriage, an abortion? Has she had babies in the past? Is this her first child? We're going to get a full med-surg history from her. Has she ever been in any kind of surgeries, anything like that? And then we'll do a family history of her side, the dad's side, and their backgrounds, grandparents, any kind of issues we might need to know. We'll go ahead and figure that out real quickly. And a social history. Has she ever done drugs? Does the dad do drugs? Does the dad smoke? Anything like that. We want to know what is going on and what kind of environment she's in. Is she in an abusive relationship? Does she have a home? Is she at risk for violence? So we're going to get a good, thorough social history. Okay, so reproductive history, terminology. With OB, you need to know the terms. That is vitally important to know and understand the vocabulary. You will do well in this class if you can figure out the vocabulary and understand it. So first off is gravida, and that is the number of pregnancies the woman has had. Nulla gravity means she has never been pregnant before. Multigravity, the woman has had more than one pregnancy. So multigravida, she's 2 gravida, she's had 2 pregnancies. And parity communicates the outcome of the previous pregnancies. How many children does she have? 2 para, 2 children. Okay, also we do GTPAL, GTPAL. And that is gravida, the number of pregnancies again, term, the number of pregnancies that ended at term or at or beyond 38 weeks, preterm, that was any babies born before the end of 37 weeks, 20 to 37 weeks, Abortions, that's going to be the number of pregnancies that ended before 20 weeks gestation, whether it was a miscarriage or an elective abortion, we still have it termed abortion. And then living, the number of children delivered who are alive when the history is being taken. Okay, so again, first prenatal visit, she's going to have a full physical examination, a full head-to-toe assessment. The doctor is also going to do a vaginal speculum exam, so be prepared for that. He might actually do a vaginal ultrasound too, to determine estimated due date and lay eyes or view the baby through ultrasound. A bimanual examination of the uterus. Now you'll see a picture of this on 138, and his top of his hand is feeling her uterus, her stomach, but then his second hand is in the vagina and it's feeling the uterus, and by doing that he is able to tell how big the uterus is and take a guess of how far along she is. So there's several elements that determine her estimated due date and how far along she is, and several different ways of the physician figuring that out. We're also going to be taking a plethora of lab work from her. She'll get a complete CBC done. She'll get blood type and antibody screens, tests for the presence of infection. She will have a pap smear done. And then we have teaching. Anytime you are around a patient, you always have the opportunity to teach. And with her, this is going to be an opportunity to teach about substance abuse. Is she using any kind of alcohol? Is she smoking? Is she doing any of those higher risk behaviors? And if she is, we want to teach her the risk of them and why it's dangerous not only to her but to the fetus, and why she needs to go ahead and stop those things. We want to teach her about diet, exercise, nutrition. What kind of nutrition will she need being pregnant now? She will need an additional amount of calories, and what are the good foods to take those calories in from? How can we help her create a balanced nutrition? And then infection control and medications. We need to make sure that she tries to avoid sick people as best as she can, not always a possibility. And then medications. Does she have any chronic illnesses that she is on medication for? And looking at those medications, are they dangerous to the fetus? Do we need to switch her over to something less dangerous? And as we look at medications, we'll start looking at categories as well, and what kind of categories those medications fall under. When you're looking at your drug book, you can see category C, category X, and that's whether or not it's harmful to the fetus. So we'll take a look at her medications and make sure that none of her medications would cause harm to the fetus. So methods of determining the due date. We have Nagel's rule, and that is, again, adding 7 days to the date of the last menstrual period and then subtracting 3 months, and you'll get her estimated due date. You also have the pelvic exam, where the practitioner is able to feel the uterus and determine the size to determine how far along she is in her pregnancy. And then also the sonogram, high frequency sound waves, which reflect off the fetus and the maternal pelvic structures, allowing for visualization of the fetus. So this is usually the first time the parents will see their baby, which is probably the most enjoyable one out of the three for them. Okay, so risk assessment. This woman is coming in. We have to also gather a risk assessment on her. So we're going to take into account all the information from her history, her physical exam, and her laboratory tests, and see, is this pregnancy a high-risk pregnancy? Is it a low-risk pregnancy? So some of the factors that are risks during pregnancies: a negative attitude towards the pregnancy. Is she excited about this pregnancy, or was it planned, or was it unplanned? Is it a wanted pregnancy? Those kind of give us a clue of whether or not this baby will be cared for later. Now remember, the first trimester, a little bit of uncertainty is normal, but by the second trimester they should be kind of transforming into that role as parent and being excited about the baby. If they're not, or if it's by the 3rd trimester and they still haven't changed that attitude, we would start looking at this pregnancy as a little bit of a risk in that factor, and we would want to make sure that this baby would be cared for, or that we can help the mother work through those feelings of maybe not wanting this baby right now, or looking at adoption or something to make sure that this baby is well taken care of. Another factor, is she seeking prenatal care, or did she start seeking prenatal care late into the pregnancy? We have to look at all the factors, all the culture, economical issues behind that. Is it a money issue? Is that why she hasn't come in? Is it more just neglect, that she would rather go and do drugs and not really worry about the baby? Cannot tell you how many times we've had mothers come in to the ER 40 weeks pregnant and they did cocaine the whole time. It's a sad story, but it's very true, and it happens more frequently than we really want to discuss, but that's something we have to take into consideration. Any kind of maternal substance abuse, history of complications with previous pregnancies. Has she had any stillbirths or miscarriages previously? If so, then she might be at a risk. Presence of maternal disease, inadequate living conditions. Is she living out of her car? Is she homeless? Or does she have a nice home, well taken care of, a good shelter? Domestic violence or physical abuse. Is she being abused? Will that put the baby at risk? And does she feel safe in her environment? Age, of course, anything over 40 puts that pregnancy at a higher risk. And then, is it a planned pregnancy or was it an unplanned pregnancy? Were they able to be on prenatal vitamins? Were they drinking beforehand? Looking at things like that to just see what the risk is of this pregnancy. So with subsequent prenatal visits, usually the client is going to be seen just once a month from weeks 1 through 32. And then she'll start being seen twice a week, every 2 weeks for weeks 32 through 36. And then at week 36, she'll be seen weekly. Usually these visits include getting the weight, the blood pressure, the urine, protein, and glucose, and then checking the fetal heart rate. And I want you to think about this. Why are we so worried about her weight? Why are we checking her urine? What are we wanting to look for in that? Why are we worried about her leaking protein or leaking glucose? And we'll get more into that, but I want you to think about those things. We're also going to be regarding the danger signs of pregnancies, asking her about, is she feeling the fetus move? Is she feeling the baby kick? And she needs to be feeling at least 10 kicks every 2 hours. If she doesn't feel that, we want to encourage her to maybe go to a quiet place, lay on her side, and drink a cup of orange juice, sit there and count until she gets at least 10 counts in 2 hours. If she doesn't, then we want her to come in because there could be a problem with the baby, and we want to check that out and get further information about that. We're also looking at contractions. Sometimes she might have Braxton Hicks contractions, and those are false contractions. And so we have to teach them what is the difference between real contractions and those Braxton Hicks contractions, practice contractions. And with Braxton Hicks contractions, there is no change in the cervix. That is how we know that they're just false contractions. Of course, she isn't going to know that because she will not be checking her cervix. We would not encourage her to do that. But she would have to come in if she really thought that she was having contractions and they were frequent and consistent. And then we would have her come in and we would do a vaginal exam to make sure that she wasn't dilating or phasing. That's how you know real contractions versus false contractions. Is she having any kind of bleeding? Is it spotting or is it heavy bleeding? Anything like that, we would want her to come in and we would have to check that out. Did her membranes rupture? That's the sac surrounding the baby, the amniotic fluid. Often you hear, my water broke. that's what that is talking about. So if it did, we would be very concerned and we would want her to come on in, or depending on how long it has been since her water broke, if she is full term and ready to have the baby, or if she's not, we might have to put her on bed rest and monitor very closely for that. Okay, so the practitioner also is going to be measuring the fundal height in centimeters. And what that is, on page 139, you'll see the practitioner going from the symphysis pubis bone all the way up to her stomach. And that is going to be measuring the height should match up with the number of weeks she's pregnant. And it usually starts about 18, goes to 32. You can measure it pretty well then. And it's usually off. It'll go all the way up to 40 weeks, but it'll usually maybe be right on. It could be off 1 or 2 centimeters, and that's fine, but that's usually a good estimate of how far along she is. Okay. All right, screenings are done all throughout the pregnancy, and that means multiple times of lab work, urinating in a cup, different things like that. One lab that is done is the MSAFP, and that's the maternal serum alpha fetoprotein screening, usually done at 15 to 20 weeks. Now, whenever I'm looking at this and whenever I'm talking to you guys, I don't want you to get too caught up on memorizing when the weeks are. I want you to know about the test and why the doctor's ordering these labs, but as far as knowing that at 28 weeks we've got to do the Rho negative test, it's not my concern that you know that as much as you know, why are we testing her for this? Why does it matter if the mom is Rh negative and the baby is Rh positive? And why would we give her this shot for RhoGAM? And what does it mean screening for antibiotics? That's what I want you to look up. That's what I want you to understand. Not so much of just all this memorization of 15 to 20 weeks, we're going to do this test. That's kind of the doctor's responsibility. He knows when he's going to order those tests, and you as the nurse needs to know why they're being ordered and what to look for. Yeah, if he slips up and maybe forgets to order a test, that's when we step in and we say, oh, don't you want to order that MSAFP on this patient? And you say, oh, yes, I needed to do that. But for right now, I want you to focus in, why are we ordering these tests and what do we need to look for, okay? At 37 weeks, 35 to 37 weeks, we're going to do a GBS Group B streptococcus test. Excuse me. Okay, and so with that, if she is positive, then we are going to go ahead and treat her with antibiotics, and we want to treat her before she has the baby. If she's negative, then she doesn't need any antibiotics. She can come on in. And a lot of times in the hospital, as soon as she comes in, they'll be asking, when was your last menstrual period, estimated due date, and whenever they start admitting her in, they'll be asking, do you know what your GBS was? Was it positive, was it negative? And if she doesn't know, then they might go ahead and treat her. Of course, they would call over to the doctor's office. If the doctor wasn't in for some reason, weekends, nights, whatever, and didn't know for sure, then they would go ahead and treat her just to be safe. All right. Assessment of fetal well-being during pregnancy. We want the woman to be counting fetal kit counts, and this is huge. This is just a screening test for us. It's letting us know that that baby is doing well and that we don't have anything to worry about. As long as you feel that baby moving, the baby should be doing well. Now, what if the baby isn't moving for a while? Like I said, lay on its side, drink some orange juice, but if it's been multiple hours and you have not felt that baby move, then we're going to have that patient come in and we're going to do an ultrasound on her. We're going to lay eyes on that baby and make sure that baby is doing well. An ultrasound is going to be our diagnostic gold standard, and that's because we can see. There's 2 different versions of it. You can do the trans-abdomen ultrasound, and that's the jelly on the belly and you're able to see, or an endovaginal trans-ultrasound. And either one of those, like I said, gold standard, we're able to see that baby. We're able to see the baby kicking, moving. You can look at the blood flow. Well, you know that that baby's doing okay by those things. Another way is the Doppler. You're able to put the Doppler on the mama's stomach and listen to the baby's heartbeat. Another type of screening is going to be the maternal serum alpha-fetoprotein screening, and that is going to be in your book, page 142. I want you to look those tests up. I want you to understand those tests and know what they're for. Triple markers, same thing. And these are, again, they're screening tests. They're not diagnostic, but sometimes they let us know exactly what's going on with the baby. Maybe there's a problem. It shows us neural tube defects. Can we look at that kind of early? Do we need to do more for them? Some parents opt out of it. They say, whether we know or not, it's not going to change the outcome of the baby, and we're not going to do anything different about it. So some parents say we don't even want those tests done, and at this point, a lot of these tests are still optional. Amniocentesis, this is completely diagnostic. Chorionic villus sampling, it is also diagnostic. With the amniocentesis, they are actually going in with a needle to the mother's stomach and getting a sample of that amniotic fluid. And so this can be a little bit of a risk to the baby. They do have to sign a consent, as well as the chorionic villus sampling. It's going in and getting a little bit of a sample tissue and testing that to see if there's any chromosomal defects with that baby. Percutaneous umbilical blood sampling, again, it's diagnostic, going into the umbilical cord. A non-stress test, diagnostic, and we'll talk more about all of these things in class, but I do want you to go ahead and look them up and understand them before you come to class. Contraction stress test, diagnostic. Biophysical profile, BPP, we will be talking extensively about all of these tests. And you also have a case study, so go do the case study. I'm not going to give you all the answers just yet, but we will be talking about this in great detail. Alright, so now we're at the nurse's role in prenatal care, and I want you to be brainstorming. Whenever you're doing these things, I don't want a huge, extensive care plan, but I want you to be able to kind of think through these things. An assessment, what does this patient look like? Not overall, but think specifically, what does this patient right here, how do I assess her? What are her needs? Yes, she is pregnant, but what other needs does she have? Does she have any chronic illnesses? We have to be thinking through all of these things. Nursing diagnosis, yes, pregnancy is one of those nursing diagnoses, but again, does she have any other chronic problems? And does she have any psychosocial problems? Is she a candidate for abuse or anything like that? And from those things, we're going to identify her. We're going to figure out how we can plan for her, how we can help her achieve a good, healthy pregnancy. And we're going to implement those things. So be thinking through those things. Like I said, it doesn't have to be a long, drawn-out care plan, but I want you to be able to think about those things and figure something out relatively quickly. Common complaints of pregnancy. Okay, NCLEX loves to ask, how will you fix these things? So when you're looking through this big, long list of common complaints of pregnancy, think, how can I help this woman's anxiety? And maybe you're thinking, well, I'll just give her a Xanax. Okay, maybe, but we're always thinking least invasive first. You want to do the most least invasive thing first. So if you can talk to the patient and help her calm down and get that anxiety down before giving her a Xanax, that's obviously what NCLEX wants you to do. It's what your test wants you to do. It's what I want you to do. So think about those things. Least invasive first. Nasal stuffiness, think about a humidifier, getting her a humidifier. Nausea, how can we help her with nausea? Yeah, she might have to go to Finagrin, but before we do Finagrin, we can tell her to keep crackers by the side of her bed and a little bit of water, and before she gets up, maybe taking a little nibble on those crackers and sitting up slowly, things like that. Feeling faint? Sit up slowly, drink some water. Frequent urination. Not a whole lot you can do about this because we do want to keep her drinking and hydrated and all, but just know that it's positioning and that it will get better. That it first trimester, last trimester, yes, but in the middle you'll have a little bit of relief. So that second trimester, look forward to that one. Increased vaginal discharge, shortness of breath, heartburn, backaches, round ligament pain, trouble sleeping, leg cramps, constipation, and hemorrhoids. How are we going to help this lady get through these complaints? Okay, so some of the teaching topics for self-care during pregnancy. Like I said, you have so many opportunities to teach, and one of the biggest ones is what kind of diet is she on, and how are we going to help her maintain a balanced diet. Dental hygiene, exercise, hygiene and clothing, breast care, sexual activities, employment, travel, medication use, substance abuse. All of these things we must address with the pregnant client, because it does change. It changes from just you and I. Maintaining safety of the woman and the fetus. So we want to monitor for warning signs at every visit. Is this woman at risk for domestic violence? Does she have any kind of risky behavior, or should we be concerned about that? Elevated blood pressure is reported immediately if accompanied by headache, epigastric pain, or blurred vision. We are automatically thinking preeclampsia or eclampsia. Eclampsia goes into seizures, and so we're very concerned about that. And how do we prevent that from occurring? We're going to monitor her blood pressure very carefully, and we're going to tell her to report any kind of signs like a headache, blurred vision, or any kind of epigastric pain. We're preparing the woman for labor, birth, and parenthood. Sometimes the scariest part of it is just not knowing. So if we can educate our patients and let them know what to expect, it will take down that anxiety for them. So teach them how to pack for the hospital or the birthing center. What do they need to bring? What would be comforting to them? And what's kind of a necessity? Communicating expectations about labor and birth. Do you have a birth plan? Some plans are extensive, 20 pages long, of how they want the lights set and what kind of music they want played. And other people are just like, pretty sure I just want an epidural and that's it. Don't even care. When I walk through the door, give me an epidural. So all these birth plans are very, very different. Choosing a support person. We always recommend having somebody there to support them, some support person there. Child birth classes, educational classes. The hospital offers these classes frequently, so we want to encourage the women and their spouses, partners to go to that as well. Pregnancy and postpartum exercise classes. You can exercise while you're pregnant, and it's actually encouraged. So we want to teach her about good, healthy classes that she can do. We don't want her doing strenuous things that might hurt the baby, but we do want her working out. And then, of course, there's breastfeeding classes. Are you going to breastfeed or bottle feed? And maybe just she might actually want to breastfeed, but she's scared of it because she doesn't know anything about it. Well, there's plenty of classes to help her with that, but as a nurse, we want to be able to be there to answer all our questions and educate her on that. And if we can't answer all our questions, then point her to the right person. We have lactation nurses who specialize in that, so we definitely want to point them in the right directions. There's also baby care and sibling classes. So there's so much education out there. We just have to know where to direct those women to. Okay, so for this, I want you to look up ATI Chapters 2, and we will discuss the rest in class. All right, thank you.